Hello, I'm Michael Pinsky, and this presentation is on biventricular interdependence, the effects of the right ventricle on the left and the left ventricle on the right. It is not a two-way street. I have no conflicts of interest with regards to this presentation. When we look at the heart contracting, it's absolutely clear that both ventricles beat at the same time, share a common interventricular septum, and are housed by a common pericardium. So when we think about ventricular interdependence, what we're saying is the changes in the filling pressure volume of one ventricle affects the performance of the other ventricle. Diastolic interdependence, which is what most people think of when they talk about ventricular interdependence, means the changes in one ventricle's end diastolic pressure volume inversely alters the other one's end diastolic volume. So if the right ventricle gets bigger, the left ventricle gets smaller. Systolic interdependence also occurs, and this is that if one ventricle's ejection pressure drastically changes, it alters the other ventricle's ejection performance. We can consider these interdependences to be due to both parallel and series interactions. Why do I mean those? Parallel is the fact that since both ventricles have the same beat frequency, diastolic and systolic times, and share a common septum and ventricular pericardium, the effects of one on the other will be immediate and in the same beat. That's a parallel effect. However, if I decrease the amount of blood flow or increase the amount of blood flow to the right ventricle, it after 3 or 4 beats must change the flow of the left ventricle. And the same on the other way around. If left ventricular output goes down, eventually the right ventricular output must go down. And thus, in the steady state, series effects will affect cardiac output, and that's not the same thing as ventricular interdependence. So diastolic ventricular interdependence, we have an absolute biventricular end diastolic volume that we can't get any bigger than, and that's limited by the pericardium. And thus, if either ventricle dilates up markedly, there is not enough space for the other ventricle to passively fill. This usually is manifest by an increase in right ventricular volume because the right ventricle is much more compliant than the left ventricle. So increases in right ventricular end diastolic volume decrease left ventricular diastolic compliance, causing left ventricular stroke volume to fall on the exact same beat based on the Frank-Starling mechanism of decreasing preload. This is normally seen with forceful inspirations against an airway, which is exactly what you see with bronchospasm or laryngeal spasm or fighting a ventilator. And it's the basis for the concept that we all know called pulsus paradoxus, that with inspiration, the arterial pulse pressure falls. Pulsus paradoxus is also seen with other forms of tamponade, such as pericardial effusion, tension pneumothorax, and hyperinflation. This was initially described by Taylor many years ago. If this is the basic left ventricular filling, and all we do is we increase the amount of volume that was present in the right ventricle from 0 in white to 23 to 35 to 47 mLs, you can see that the left ventricle gets stiffer. So that for the same filling pressure shown as 2, the amount of volume in the left ventricle falls. So to maintain a constant end diastolic volume for the left ventricle, I would need to markedly increase the filling pressure of the left ventricle because its compliance is decreased. This is a form of parallel interaction, which as the right ventricle gets bigger, it pushes the pericardial interventricular septum from the right to the left. Diastolic ventricular dependence is primarily from the right to the left on a beat-to-beat fashion because the major changes in diastolic volume during ventilation occur with the right ventricle because venous return can vary widely. But if right ventricular stroke volume changes after a couple of beats, left ventricular stroke volume must change by the Frank-Starling mechanism as well, but that's a parallel reaction. This is the physiologic basis for positive pressure ventilation induced stroke volume and pulse pressure variation that we see and use for prediction of volume responsiveness. And it also explains why decreasing right ventricular end diastolic volume in patients with acute cor pulmonale increases left ventricular diastolic volume and stroke volume. Let me show you. In this example, we have an intact animal that's breathing spontaneously on the left and with positive pressure on the right. And we're measuring stroke volume in the right and left ventricle and various things. With the spontaneous inspiration, you see pleural pressure fall. This causes an immediate increase in right ventricular volume and stroke volume. As the volume goes up, there's a exactly parallel fall in left ventricular stroke volume during spontaneous breathing, and you get a decrease in pulse pressure. That's ventricular interdependence. But watch, with positive pressure breathing, as the airway and pleural pressures rise, you get a fall in venous return to the right ventricle. But note the left ventricle doesn't change at all. It only falls several beats later. That's not ventricular interdependence. That is a series interaction. And the reason why we can use positive pressure breathing to look at volume responsiveness. Furthermore, if you take a person with heart failure and you give them fluid, you actually impede left ventricular function, as Francois Jardin showed many years ago. Let's now go to the other part, systolic ventricular interdependence. Since the heart shares a common interventricular septum and the left ventricular fibrils connect directly to the free wall of the right ventricle, you can have significant common sharing. We looked at this in an animal model in which we measured biventricular pressure volume loops and had a snare on the aorta and the pulmonary artery and the IVC. These are data in which we caused an increase in pulmonary artery pressure by snaring the inferior vena of the pulmonary artery. And as you can see, the right ventricle dilates up. At the same time, left ventricular end diastolic volume falls. So this is ventricular interdependence impeding left ventricular ejection. There is a decrease in left ventricular compliance. Sorry. We also looked at this later in a much more stable model, and you can see that when we increase pulmonary pressure, here shown on the right, all that we do to the left ventricle, shown on the left, is to make the end diastolic volume smaller. So this is a parallel interaction from increases in right ventricular ejection pressure impeding left ventricular stroke volume by decreasing left ventricular diastolic compliance. As the ventricle increases its pressure, we decrease left ventricular end diastolic volume. Okay. This impedance requires a few beats and is more of a series interaction. What about the other side? Well, Domino showed that when he had a left ventricular assist device and he varied the amount of contraction of the two ventricles, he discovered that as he varied the amount of left and right ventricular contraction, approximately 50% of the developed pressure of the right ventricle occurs from left ventricular contraction, not right ventricular contraction. And this can be nicely shown in this example, in which we take a left ventricle on the left and we simply occlude the aorta. As the arterial pressure rises, you note that the right ventricular end systolic volume markedly increases without a change in end diastolic volume. This is a systolic augmentation of the right ventricle. This was also shown by us in a larger animal model, where as you increased the pressure in the left ventricle, shown on the left, the right ventricle got bigger, as you can see, improving ejection. And if you progressively increase the pressure on the right ventricle in a series fashion over 4 beats, you see that the right ventricle progressively gets smaller with more improved performance. So increases in arterial pressure markedly improve right ventricular systolic performance. Okay, this is important because we often have to treat cardiac shock from acute pulmonary hypertension due to pulmonary embolus or other things. The best treatment for that is to restore coronary perfusion pressure and increase ventricular pump function by raising mean arterial pressure. If you give fluids to these patients, a little bit may be okay, but more than that will probably cause overdistension and death. This was brilliantly shown by Ganoni many years ago, in which he took a baseline animal model and he had their mean arterial pressure and cardiac output. He gave them volume and the mean arterial pressure, the mean pulmonary pressure went up a bit and cardiac output went down. He had another baseline. Then he gave glass bead embolization right there. And that caused a profound increase in mean arterial pressure and cardiac output fall. When he gave volume, cardiac output fell even further and cardiac output fell as mean arterial pressure fell slightly because he was in cardiogenic shock. At this point in time, with a very high PA pressure, he gave norepinephrine, and that caused the cardiac output to go up, even though the mean pulmonary pressure went up because he improved contractility. So ventricular interdependence. Diastolic ventricular independence is primarily from the right to the left because as you increase left ventricular volumes, it doesn't affect the right ventricle very much. It has both parallel and series interactions, and it allows us to use pulse pressure variation and stroke volume variation during positive pressure ventilation to predict volume responsiveness. Systolic ventricular independence is primarily from the left to the right because the left ventricle has all the energy. It explains why we see RV failure during LVAD insertion and explains why the treatment of acute cor pulmonale from pulmonary embolus is best treated by norepinephrine. Thank you for your attention.